And hello, everyone. I'm Jason. I'm the host today from Aohua. And I want to say welcome to Aohua Vet webinar. And first, I want to do some introduction of our company. Our company, Aohua, was established in 1994. We have focused on endoscopy system for 29 years. And today, our webinar is aimed to bring veterinary endoscope users together and to share their knowledges and their experiences. Okay, next, let me introduce our friend, the speaker today, Dr. Vasiliki. Her clinical interests including canine and feline gastroenterology, nutrition, and diagnostic interventional endoscopy in companion animals. She holds a GP cert in small animal internal medicine and a GP cert in endoscopy and endosurgery from the International School of Veterinary Postgraduate, and also a PG cert in small animal medicine from Harper Adams University. Okay, so it's your time, Dr. Vasiliki.
Thank you very much, Jason. Thank you. And I'm really, really excited about today's topic. You have to make me a host in order so that I can share screen because I can't.
Yeah, okay.
Initially, I have thought about putting all the chronic enteropathies in one basket, but I think that it would be better off to take it in parts so that we actually clarify some misunderstandings that I am certain that you have, as I had previously in the past about chronic enteropathies. So let's just share and see what we're going to see in this session. So part one of chronic enteropathies is going to be about antibiotic responsive diarrheas. Is it SIBO? And we're going to clarify what is small intestinal bacterial overgrowth. What is small intestinal dysbiosis? Are these the same terms for idiopathic antibiotic responsive diarrhea? And what is antibiotic responsive diarrheas? Which are the antibiotic responsive diarrheas in canine and feline gastroenterology? So being a Greek, I always have to have a reference in Greece. So Hippocrates, which was the first official medical professional, has said back in ancient Greece, has said that let food be thy medicine and medicine be thy food. And he couldn't be more true and correct and precise, because we are what we eat. And you're going to figure it out when I show you this next slide. This next slide shows the distribution of chronic enteropathies as the cases are admitted to a first opinion clinic, not to a referral clinic, actually. So 65% of the cases are food responsive enteropathies. These are the FRE. These are the cases that you shouldn't miss. These are the cases that you should never refer to any referral clinic. And you see that this is a massive percentage, the food responsive enteropathies, which means that without any medication, with proper food, you can actually solve these cases. You just have to be patient sometimes. I know that a lot of you tell me that we have given, we have done the hypoallergenic trial and we haven't succeeded. But sometimes dogs that do not, or cats that do not respond to one hypoallergenic diet does not mean that they will not respond to another hypoallergenic diet. Maybe they will respond to a novel protein diet, for example. And other times, the food trial has not been performed correctly as it should. So when you ask, for example, open questions like when you ask closed questions, the owner, like, do you give anything else? Of course, the answer will be no. just the hypoallergenic diet. But if you ask, for example, oh, okay, he's in this hypoallergenic diet. Does he like to eat anything else? Does he like to consume anything else? Then they will probably tell you, oh, yes, they like these treats, you know, that we bought there. Or you can discover more things if you start being detectives. Unfortunately, doctors, you know, we're kind of detectives as well. So ask the correct questions in order to get the proper answers to help you in your clinical history. These are the cases that I get. Half of these cases of the food responsive enteropathies are being referred to specialists for endoscopy. And this shouldn't be the case. These are, as I told you, the cases that should stay in your clinic, and you should make, you know, the profit out of these cases. The rest of the cases, 15% of the cases, are the ones that we call antibiotic responsive diarrheas. And this is our topic today, is these 15%. And you might say, you might ask yourselves, why did we, you know, start from this 15% rather than going to the 65%? Because these are the cases that you easily miss and you give steroids. And I don't want you to do that. These are the median age of the cases that are presented to your practices or to your clinics with antibiotic responsive diarrheas are young dogs, young German Shepherds sometimes, but large breed, giant breed dogs that have a median age of 2 years, 1.5 years. Don't give steroids right away to these dogs. Do your food trial and then give antibiotics, as we will say. Of course, you have to, as we will discuss during the course, you will have to eliminate, to rule out all the other underlying diseases that could cause, extra intestinal diseases that could cause diarrhea. And 15% of cases are the steroid responsive diarrhea cases that they need immunosuppression of some kind. But you see that these are only 15% of the whole pie. And we tend to give cortisone just like that. And this is not correct, okay? And the non-responsive enteropathies, which are other enteropathies that we have tried a proper food trial, that we have tried antibiotic responsive antibiotic trials, that we have tried some kind of an immunosuppression and still they do not respond. So this is the new classification of chronic inflammatory enteropathies and IBD, and we will say if this term is correct or not. So the inflammatory bowel disease corresponds to only these 15% of cases. So inflammatory bowel disease, there's an amazing paper here from Dr. Dandrieux, and it actually compares the inflammatory bowel disease versus the chronic enteropathy term in dogs. Are they one and the same? Are they different? Because the term that we're using now, and it has a clinical significance also, it's not just terminology. So in humans, the most famous IBD versions of IBD are Crohn's disease and ulcerative colitis. So the current concept of IBD, both in animals and in humans, is that we have a genetic predisposition, and then we have this interaction with food components, so what we eat, with environmental factors, and of course with the intestinal microbiota. These are all combined in order for an inflammatory bowel disease to be expressed and to give clinical signs. This is the same things both in humans and in dogs. But there are a lot of differences between humans and dogs in the treatment approach. And you will see that in humans, we go with 5-ASA drugs, we go with antibiotics, we go with, then we go with corticosteroids, then we go with immunosuppression and cyclosporine, and then we have biological therapy. In dogs and cats, it's totally different. The approach that we have in IBD cases is dietary modification, then antibiotics, and then immunosuppressants. And this is the correct way to go. So there are a lot of differences in terms of treatment between humans and dogs. 40 to 50%, as you see, of human patients will undergo surgery, having IBD, will undergo surgery in order to solve their IBD complications. Within 10 years of the diagnosis, with a recurrent rate of 15%. This doesn't happen in dogs. In dogs, we never escape to surgery, or we hardly ever do in order to solve IBD cases. And most of the dogs will not even get into immunosuppressive treatments. Most of my cases, I tell you that 75% of my cases are solved with dietary modification and with antibiotics periodically, and rarely with immunosuppression. So these are the terms that I really want us to clarify today. And these are the terms that were actually confusing me when I started figuring out what was each one of those terms. So we have the small intestinal bacterial overgrowth, the SIBO. Does it exist? What is it? The small intestinal dysbiosis, the antibiotic responsive diarrhea, primary and secondary, and also we have the bacterial enteritis. Is the bacterial enteritis an antibiotic responsive diarrhea case as well? Or are all bacterial enteritis cases antibiotic responsive diarrhea? And when do we use antibiotics in gastroenterology, which is, I assure you, it's not in our everyday practice. Most of the cases do not need neither antibiotics nor immunosuppression. So let's start off with the dysbiosis. What is the dysbiosis? The dysbiosis does not have to do with numbers. It's a qualitative misregulation of the microflora. So it's the disturbance of the intestinal microbiome in terms of diversity. So we have less diversity of the bacteria in the bacteria in the microbiota of the microorganisms, and also we have species alterations. The good bacteria are going down, are being decreased, and the bad bacteria are being increased, like Clostridium species, not Clostridium difficile, for example, is being increased, and Clostridium hiranonis is being decreased. And Clostridium hiranonis is a very, very important microbe, very, very important bacteria, because it actually transforms primary to secondary bile acids. So the dysbiosis could be primary or could be secondary due to an underlying disease. Primary idiopathic in German Shepherds, for example. This is the disease that we're talking about. In German Shepherds, it has been proven that it's not a matter of a bacterial overgrowth. It's maybe a matter of, it's probably most a matter of dysbiosis. So we call it primary idiopathic dysbiosis, or antibiotic primary idiopathic antibiotic responsive diarrhea, long terms. And of course, the dysbiosis could be secondary due to, this is a bit contradictory, due to a long period of use of antibiotics. We could have an intestinal dysbiosis due to enteropathies, due to pancreatitis. All of these diseases could cause a secondary dysbiosis. What about small bacterial overgrowth? What is SIBO, and does it exist to dogs and cats? Oh. This is very, very sensitive here. So SIBO is the uncontrolled proliferation of small intestinal flora, which means that this is numbers. We're talking about numbers here. This term is not longer used, as it was based on quantitative cultures of bacteria in the small intestinal GI tract, which was never confirmed by newer PCR methods, as you see. So idiopathic SIBO, though, is recognized in humans and is an entity. It is a pathologic entity in humans, but we cannot extrapolarize that to the canine and feline patients. So especially in children, the overgrowth develops in the pockets of fluids between annular mucosal folds. Okay, so these anatomical structures are not present in dogs and cats. So the existence of SIBO in humans is accepted, but in dogs and cats, we have to rethink and maybe rearrange our thoughts and the diseases that we will encounter. So secondary small intestinal bacterial overgrowth. Yes, probably due to secondary diseases like exocrine pancreatic insufficiency, when we have maldigestion and maldigestion and malabsorption syndromes, partial obstruction, partial intestinal obstruction, or dietary sensitivities. These entities, these diseases could lead to secondary bacterial overgrowth. And what about idiopathic SIBO, which is not SIBO, it's dysbiosis now. We're going to say that dysbiosis, this is the idiopathic antibiotic responsive diarrhea. So I hope that we pretty much understood that in dogs and cats, we cannot talk about primary small intestinal bacterial overgrowth, maybe secondary. We mostly talk about dysbiosis, which has nothing to do with numbers. It has to do with the content of the microbiota, the species that actually take part in the microbiota, the biodiversity of the microbiota. Okay, and is it possible to count the intestinal bacteria? This is very, very difficult because we have very hard time flaws in the collection technique. We have flaws in the culture techniques. We have flaws, we're talking about the duodenal bacteria in the small intestine. The reference ranges are not something that we have actual values, are not evidence-based. And what about the effect of coprophagy on duodenal bacterial numbers? We know that a lot of animals that, for example, have exocrine pancreatic insufficiency, or a lot of animals with small intestinal diseases do what we call PICA, allotriophagia, which means coprophagy sometimes. So does this alter the diversity of our intestinal microflora? Sometimes you do fecal cultures when you have animals with diarrhea, but the fecal cultures are actually the bacterial load that's in the large intestine, and it doesn't represent the bacterial load that's in the small intestine. You have to keep this in mind as well. And this is why bacteria cultures, fecal bacteria cultures, are not that useful to in canine and feline gastroenterology. Not to mention that a lot of pathogenic for humans, like Salmonella or Campylobacter, are, how do we say that, are not always pathogenic, or periodically pathogenic under certain circumstances in dogs and cats. So, is idiopathic SIBO the antibiotic responsive diarrhea? It's very difficult to define SIBO, but it's very easy to define antibiotic responsive diarrhea due to the responsiveness to antibiotics. So there are great variations also in bacterial numbers between individuals, between species, and also in the same individual, within the same patient on a daily basis, there could be great variations of the bacterial numbers. So let's now go to the idiopathic antibiotic responsive diarrhea, because I really do not want you to miss any of these cases. It is presented in large breed and giant breed dogs. Young dogs, these are young dogs that are coming to your clinic. So we could encounter IBD in a German Shepherd, but a German Shepherd that's 6 or 7 years old, but you will encounter most of the times antibiotic responsive diarrhea if a German Shepherd or a large breed or a giant breed dog comes at 2 years of age, at 1 year of age. And I want you to keep that in mind, okay? So this is mistaken. This disease is mistaken for exocrine pancreatic insufficiency. It has the highest recurrence rate. So when we're weaning these animals off antibiotics, then they recur, they tend to relapse, okay, more than the food responsive diarrheas and more than the steroid responsive diarrheas. So we have at least 4 allotypes, mutations of the IgA gene in dogs. And all of the German Shepherds tested so far have 1 allotype, variant C. They're either clinical healthy or they have diarrhea. They're fecal IgA deficient, which doesn't mean nothing because this is not, there has been no association between this variant and the disease. So all of the German Shepherds that are admitted, either healthy or with diarrhea, yes, they belong to the variant C, but we haven't been able to establish yet an association between disease and this variant. So as I told you, this is how the German Shepherds are admitted to our clinics, emaciated with coprophagy. Most of the times their appetite is normal and they have symptoms of mixed origin diarrhea, both from the small intestine and the large intestine. So they have colitis, they have large volumes of feces, they have increased defecation, frequency of defecation. They also have intense borborygmus. So they have mixed symptoms from both small intestine and large intestine. In young German Shepherds, we have the suspicion, keep always the suspicion of antibiotic responsive diarrhea. And in older German Shepherds, we always have the suspicion of inflammatory bowel disease, steroid responsive enteropathies. Both in these cases, the total receptors 4 are increased and the total receptors 5 are decreased. And we're going to see what are these total receptors. So why do we have this entity? Why do dogs respond only to antibiotics without any, any response to cortisone therapy or to immunosuppressive therapy? So it could be abnormal host bacterial interactions. German Shepherds with antibiotic responsive diarrhea have increased lamina propria CD4 T cells. I know that's a bit boring, but it's very, very important to understand the disease. So this might be an immune dysregulation. The second is the defective IgA secretion, but please note that it's at the small intestinal mucosal surface. Okay, affected German Shepherds may have defective small intestinal IgA production, although mucosa plasma cell numbers are either normal or increased. So it's only on an intestinal level, the IgA, the defective IgA secretion. Mutations in the bacterial pattern recognition genes. So we have a lot of mutations in the toll receptors 4 and 5. We have in the major histocompatibility complex and the nodes that have been associated with the disease. And it's probably the reason why we have this antibiotic responsive diarrhea. So we have polymorphisms in the toll receptors, which recognizes the bacterial flagellin. Okay, this is what they're defective in, and this is why they exhibit what they have clinical presentation of the disease. And we tend to wonder if there is any unidentified pathogen involved in this this pathologic mechanism of manifestation. And we tend to think maybe a Helicobacter or an enteropathogenic Escherichia coli, like the attaching and invading strain that we see in the ulcerative colitis of boxer dogs. So this is an infection in the perinatal period, just as in the boxer dogs as well. So these are all the hypotheses, and unfortunately, they're hypotheses. most of them, but we have seen a pattern of the disease in dogs that they have this polymorphism in toll receptors, especially toll receptor 5. So what do we do? How do we diagnose the antibiotic responsive diarrhea? And I'm going to show you cases after that. Some would say that this is an easy peasy, diagnosis. We don't need anything. We just do an antibiotic trial and that's it. And you're probably right. A positive response to a antibiotic treatment trial with resolution of clinical signs. And when we wean the animals out of the antibiotics, when we withdraw the treatment, we see that there are relapses. This is very indicative of the disease. So the elimination of other etiological causes, of course, based on the results. So we have to have no endoscopy abnormal findings. We have to have a TLI that's normal. All the extraintestinal diseases to be ruled out. And if you give antibiotics and they respond and you withdraw antibiotics and they relapse, then this is highly, highly indicative. So, clinical suspicion, young German Shepherd dogs. We said that, and I know that you will remember it by now. Normal serum TLI, mild to moderate inflammatory changes in endoscopy. So you scope these animals and the result that you have back is mild lymphoplasmacytic enteritis. Is it inflammatory bowel disease or, the steroid responsive enteropathy? No, it could be, but if you have a young animal, as we said, you have to try other things first as a therapeutic approach. Okay, so you have, in most of these cases, the CBC and the biochemicals are normal. It's very rare in these patients to be hypoalbuminemic. Okay, and then there's the B12 and the folate, and there are a lot of variations in B12 and folate. Most of the times, cobalamin is low, and this is when these animals from polyphagic, they become anorexic. Most of these animals are polyphagic in this disease, but they can become anorexic, periodically anorexic, when the B12 levels, when the cobalamin levels are really low. And what about the folate? The folate could be high. So this is when we were talking about small intestinal bacterial overgrowth in the past, but it could also be low, and we will see why. So the treatment. Antibiotics for at least 4 to 6 weeks. Which kind of antibiotics do we choose for this disease? Oxytetracycline. Okay, it's very cheap, but you have to be aware of the color that they might give to teeth, and also because there is a massive excretion of oxytetracycline to the liver. You should not give it to liver diseased patients, okay? Metronidazole, at this dosage, 10 milligrams per kilo every 12 hours, 8 to 12 hours. In cats, we tend to use the metronidazole dosage is lower, 7.5. Okay, and tilazine, 20 milligrams given orally twice or 3 times per day. And then for the relapses, we tend to give very, very small dosages of tilazine, 5 to 8 milligrams once per day, can actually give very good control of the symptoms. So these are the 3 antibiotics that we choose. Okay, the efficacy is maintained even after reduction of dosage or the dosage interval, which means that these dogs could actually be on antibiotic for 6 months or for 8 months. So what do we do? Do we taper the dosage of antibiotics? Because we all know that this is not, for public health reasons, this is not proper to do. So we can keep them for a small period of time to lower dosages and once per day, but periodically we definitely have to stop the antibiotics. And then if a relapse if we encounter a relapse, or if these animals are resubmitted to our clinic with a relapse of diarrhea, then we can start them off on antibiotics again. And some dogs with age, they outgrow this problem. It's either the result of decreased caloric intake, or because they have a stronger and more mature immune system. They develop a more mature immune system. Metronidazole, I know that a lot of you give a combination of metronidazole with cortisone in these cases, or a lot of you, before even doing a dietary trial, you give metronidazole in order to regulate the symptoms, in order to make the symptoms of the diarrhea better. But it has been proven also that most of the cases do well, not of antibiotic responsive diarrhea, but most of the cases that are admitted with chronic diarrhea respond to dietary modifications without metronidazole, okay? Because this is the drug that actually gives most of the bacterial resistant cases. So it reduces intestinal inflammation, yes. It has an antibacterial and antiprotozoal action. Immunomodulatory effect, we haven't, proved that, but on a cytologic immunity of the intestinal tract, it has an evidence-based efficacy. It's used as a monotherapy in inflammatory bowel disease of cats, but then we have to wonder about that. Is it truly IBD in these cats, or is it some kind of antibiotic responsive diarrhea in cats as well? Caution in animals with liver diseases. In high dosages, it could cause neurotoxicosis. It has happened to me. I have confronted it 2 or 3 times, okay? And it easily rises, as I told you, antibiotic resistant with long-term use. And of course, it in the beginning, it might modify the intestinal microbiota, but long-term, it actually causes dysbiosis in the intestinal microbiota. Cobalamin supplementation. Do we give it parenterally? Do we give it orally? So you can do both. We can give parenteral supplementation once per week for 4 to 6 weeks, and then once per month for 4 months at these dosages. Okay, but oral supplementation has been proven to be to have the same efficacy as the parenteral administration. So these are the dosages. You can give it for 4 to 6 weeks daily. The only disadvantage is that you have to give it every day per os from the mouth orally, and some animals cannot tolerate that. So it's up to you. But these cases do very well on supplementation, on cobalamin supplementation. And there are also some formulations that contain intrinsic factor, that contain folate for those animals that have low folate. I can give you some names of trade names of medications. I just didn't want to add them in the presentation. And some other even contain prebiotics. You will see the one, FOS, for example. You will see the one that I have used in the next case. Okay, so this poor dog was admitted to the clinic a year ago, I think. It was 1 or 1.5 years ago. Very young one, 20 months old. Okay, and the clinical history, he actually had a very long clinical history because he has been coping with diarrheas for the last 5 to 6 months, recurrent episodes of mixed pattern diarrhea during the last 5 months. It was actually more. And the characteristics of the diarrhea were large volume diarrhea, tenesmus, which is small intestine, tenesmus, which is large intestine, hematochezia, which is large intestine, increased frequency of defecation, large intestine. So it's a mixed pattern. And borborygmus, it had a lot of borborygmy, excessive borborygmi, which is small intestinal symptom. Appetite alterations from polyphagia, scavenging, coprophagia, to periods of anorexia and hyperexia. So we have to wonder about the B12 that I told you. Whenever the B12, whenever we have hypocobalanemia, I have to pronounce that correctly because these are Greek words and I have to. So whenever we have low cobalamin concentrations, then hyperexia or anorexia comes to the surface. Okay, abdominal discomfort, colitis-like symptoms, as I already told you. Weight loss and stunting, you can see this dog is practically emaciated. And in the past, he has been administered metronidazole for long periods, for 2 months, for example. Hypoallergenic diets, two different hypoallergenic diets. Novel protein diets, febendazole as a therapeutic trial, even though his fecal parasitology tests were negative. Okay, with a very small improvement over short periods. Ultrasound was normal in this animal, not even, you know, I have palpated thickened intestinal loops, but in general, the ultrasound was normal, the CBC was normal. We will see that here. So just a quick recap on a reminder, just for you to recall the differences between the small intestinal disease and the large intestinal disease. In the small intestinal disease, we have large volumes. We have rarely we have mucus or blood or red blood. Okay, the tenesmus rare. The frequency is 2 to 3 times per day, whereas in the large intestine, we have smaller stool volume, we have fresh blood, we have tenesmus, we have increased defecation frequency, and also whenever we have a small intestinal disease, we also have other clinical symptoms like vomiting, weight loss, which is very common in small intestinal disease and less common in large intestinal disease. Okay, and let's go and see Banana's, that's his name, Banana. Banana's physical examination findings. I always want you to estimate and write down the body condition score, the muscle condition score, and in enteropathies, we're going to introduce 2 more things to always look at. Okay, so the palpation of the abdomen, mild thickening of the intestinal loops, which, to my surprise, the ultrasound did not actually verify. I thought that the loops were a bit thickened in palpation, but it was not verified. Okay, the body condition score 2 out of 9, the muscle condition score. This dog has muscle atrophy due to malnutrition, probably. So the muscle condition score is C. Although the respiratory rate, the beats per minute, normal, the mucous membranes, normal, no anemia, no nothing, the temperature, normal. The fecal score, which I'm going to show you, was very high, 67. And also we have 2 more scores to assess. And you will always do that because they're very, very this is a very useful tool that I'm giving you. For those of you who do not do endoscopy, you will not believe what you can do with these tools. These tools, the CBDI score and the CCE-CAI score, have the same prognostic value as the endoscopy, as the endoscopic results that you're going to get. And as an endoscopist, I shouldn't say that, I know, but it's the truth. Okay, let's go over. I'm sorry, these are the true, actually, feces of Banana. You see from at the same spots of the house. So sometimes, I'm so sorry, and it's noon here in Greece. For those of you who have your lunch break, I'm so sorry about the fecal scoring system. So the feces of Banana were either 6, rated 6 or 7. So they were watery, they had mucus, a lot of mucus and fresh blood, but other times they had no shape, okay, large volumes, of feces, of fecal material. So they're both from the large intestine and the small intestine, as we said. And what about these two scores? These are very easy to find in the WSABA gastrointestinal, in the consensus. They're out for free circulation, and you can actually see them here. Whoever wants them, I can give you the fact sheets also of the CIBDI and the CCCAI score. So you see that we actually evaluate 6 parameters: the attitude and activity, the appetite, if there's vomiting or not, the stool consistency, the stool frequency, and the weight loss. So these are for this is the summation of 6 variations, and these are for the CIBDI score. And from 0 to 3, we have clinically insignificant disease. From 4 to 5, we have mild IBD. From 6 to 8, moderate, and 9 or higher severe IBD. And as you recall, here we had a score of 16, which is a severe case, maybe not IBD, but a severe enteropathy. This indicates a severe enteropathy. Okay. So it's very easy to do. And in the CCE-CAI score, we also measure the albumins, if there's ascites or not, and if there's pruritus for the food intolerances, for the food allergies, true food allergies or not. So we estimate those 3 parameters as well. Most clinical studies do not show any difference between endoscopic scoring and clinical indexes. And this is very, very important. It means that if you do this, you know if you have a mild, a moderate, or a severe disease. Okay. So what do we do in this patient? We always create a problem list. And what is our problem list? Mixed origin diarrhea. We have weight loss and standing, periodical vomiting, which was very, very rare, polyphagia, pica, coprophagia, and anorexia in the last stages of the disease. Okay. And there's always we have to clarify what is maldigestion and what is malabsorption. So maldigestion is the impaired breakdown of nutrients. Okay, well, whereas malabsorption is the defective mucosal uptake and transport of adequately digested nutrients. So we have already digested them, but we cannot transport them or absorb them correctly. And I really have to make you understand this. Sometimes not all cases of diarrheas are malabsorption, and not all cases of malabsorption cause diarrhea. We could have intestinal disease without diarrhea. We could have an intestinal disease only with weight loss and cachexia. These things are totally different, and I want you to understand that. So in diarrhea, we have an increase in fecal water content with increase in frequency, in fluidity, in the consistency of the fecal material and the volume of the feces, whereas in malabsorption, it's just the defective, as we said, uptake of a dietary constituent resulting from interference with its digestion or its absorption due to either epi or small intestinal disease. So, as we said, not all cases of diarrheas are malabsorption, and not all cases of malabsorption cause diarrhea. We have a lot of small intestinal diseases that are malabsorptive diseases, but they do not have diarrhea. They do not cause diarrhea. And when these animals are admitted to the clinics emaciated, and you wonder, did they not ever have any diarrhea? And the owner says no. So the mechanisms of malabsorption are 3, actually: the luminal, the mucosal, and the postmucosal mechanisms. And small intestinal dysbiosis and the antibiotic responsive diarrhea are a luminal. They have a luminal mechanism. So let's go to see the hematology, the biochemistry, and the urinalysis results of banana. The fecal parasitology examination was negative. Okay, and we did Barman, zinc sulfate, giardia. We also did a direct microscopy for giardia, cryptosporidium with EFA, nothing, everything negative. Okay. The baseline cortisol, because we want to exclude all the extraintestinal diseases, normal. So we excluded hypoadrenocorticism. We didn't have to go and proceed and do an ACTH test because the baseline cortisol was high. Okay, the CTLI was normal, so we excluded the exocrine pancreatic insufficiency. The liver enzymes in banana were normal, so we didn't have to go and proceed to do a dynamic bile acid tests. Okay, and overall the ultrasound was unremarkable. So if an animal like that comes with diarrhea, with all the tests negative, this is when most of the vets refer to me the cases. This is when I get the most referrals because they have tried everything and all the tests are normal, and they don't know what to do. So we're gonna say now what to do so as not to refer. Okay, we also did, and you should do, this is the actual test of choice for these cases, cobalamin and folate. And don't be surprised to see that the folate is low, because I know that you have this pattern in your mind that the cobalamin should be low and the folate should be increased, but sometimes it's normal, the folate is normal, sometimes the folate could be increased, but there are a lot of times that the folate is, the folic acid is decreased. So if the folic acid is decreased, it means that we have proximal small intestinal damage, okay. And if the cobalamin is decreased, we have distal small intestinal damage. And if the folate is increased, we used to say that this is, bacterial overgrowth. It also is increased in pancreatic insufficiency and, of course, in supplementation. So high folate and low cobalamin is suggestive of small intestinal bacterial overgrowth, but is a very, very poor marker for, it has a very poor sensitivity for antibiotic responsive diarrheas. Low folate, because the folate is absorbed in the proximal jejunum. So if you see low folate, and of course you have to supplement the animal, it reflects proximal small intestinal disease, whereas low cobalamin, it reflects distal small intestinal disease because cobalamin is absorbed in the ileum. Okay. Artifacts for low cobalamin, in exocrine pancreatic insufficiency, dietary deficiency, lab error, or photodegradation of the cobalamin. I do not see now if you have any questions, I would definitely, don't leave them in the end. If you want to discuss, the case, or if you have any questions on the case, I would be very happy to discuss during the time that we are commenting on the case. We also did, due to the age of the patient, because it was a very, very young patient, without any symptoms of pruritus, though, as you've seen in the SIGDI score. Anyway, we did a food allergy testing. Is it definite? PAX technology is the best technology right now for the antigens. But even having said that, you have to interpret the food allergy, the RAS ELISA tests, or the PAX technology test with very, very caution. So here our patient, banana, is not sensitized, it does not have IgE antibodies to any food antigen. None of the food antigens are positive. Okay, so we just keep that in mind. And let's see now the gastroscopy. It was last July, it was 1 year ago that I've seen Banana. And actually, he's been doing amazingly well now, because before this lecture, I gave the owner, a phone call in order to have an update to tell you. So you see that the esophagus, yes, it has some foamy material, but it's pretty much a normal esophagus. You can see you will see in the gastroesophageal junction some small spots there that could reflect, some kind of, esophagitis, reflex esophagitis, but they are so mild, that they're unremarkable. They're not, not even detectable. You see here, not this is the Z line, okay? This that appears to be more reddish is the Z line. Okay, let's see the stomach. Unremarkable. Even though the animal has been periodically vomiting, no gastritis. This is the pylorus, this is the pyloric region. Very, very smooth and without any lesions. Mucosa. It opens and closes. No duodenal-gastric reflex disease. This is why sometimes people tell me, why are you, staying and staring at the pylorus? I'm not having a conversation with the pylorus now. I'm just waiting to see if there's going to be any duodenal fluids from the duodenum into the stomach. So you have to wait. Don't do everything in a hasty way. Okay. This is your only chance to reveal lesions, to reveal other things. So now we're going to we inspected the body of the stomach. No actual lesions. And now I'm doing the J maneuver. And also the stomach is empty. It doesn't contain any bile, nothing pathological. And it's a stomach of a very young animal. And these blue shadows here are from the liver. Okay, spleen, liver. A very, very nice and smooth mucosa. And this is the J maneuver, where we see the fundus. We rotate a bit, we torque a bit, okay? And let's go see the small intestine. I mean, we have so many diarrheas that the animal is emaciated. These are the Peyet, the plaques, the Peyet plaques that are shown. So you see pretty much normal small intestine duodenum with normal peristaltic waves, very, very mild edema. I wouldn't even say so. Very, very mildly increased granularity and friability during my endoscopic biopsies, and this blood is from me, huh? Beware of noticing what you're causing, the artifacts. I caused that at the moment that I was trying to enter the pylorus, okay? So esophagus normal, the stomach normal macroscopically, okay? And the small intestine normal. There's a very good question. Does seeing the liver means that the mucous membranes are thinner than normal? No, it happens in very young animals. It happens in young animals, sometimes you can see that. No, it doesn't mean that. Okay. But this is where the endoscopic ultrasound will help us later on. I hope that Aohua will invent for veterinary use as well, and then an endoscopic ultrasound so that we can take biopsies through the stomach as we do in humans, okay? And this makes it much, much easier when you see the organs. Okay, and now let's go to the histopathological results. And most of you, when you get these results, some of you are relieved because, you have something to give to the owners, because they say that something, is pathological. But on the other hand, if you really want to be honest with yourselves, this diagnosis is nothing. Mild lymphoplasmacytic enteritis, and if you see what my histopathologist says here, that rarely isolated, very scarcely seen lymphoplasmacytes. So no evidence of glandular atrophy or lymphofollicular hyperplasia, no dilation of lacteals. So it's practically nothing. It doesn't mean anything. And please don't go with this diagnosis and give cortisone or immunosuppression. This is not idiopathic inflammatory bowel disease, okay, steroid responsive enteropathy. In no way it is. So what did we do to banana? We gave tilazine, 20 milligrams per kg BID for 6 weeks. I would have given oxytetracycline, but it wasn't back then in circulation in Greece. So we had to order it from abroad. So we gave tilazine. I didn't go with metronidazole because this dog had a long course of metronidazole in the past and it wasn't responding to metronidazole. Okay, just in order, you might have any questions why. And so we gave tilazine twice a day, not 3 times a day. And this is a high dose of tilazine. We could even go lower with 15 milligrams per kilo. Okay, for 6 weeks. We also gave cobalamin supplementation. We have Articlux, which is a human medication in Greece. Maybe in other countries, this one that I really, really love, and I don't have, I don't even know the company because it's not in circulation in Greece, but it has cobalamin, it has prebiotic, and it also has folate. Okay. So I really love Cobalaplex. Sivamix as a prebiotic, low-fat diet. This is very, very important. This dog has not responded to any hypoallergenic diets, to novel protein diets. Let's try something else, a highly digestible low-fat diet, okay? And we also gave prebiotics, soluble fibers. These are very, very important. This is the food for a healthy microbiota. Don't underestimate the power of prebiotics and of cobalamin. Sometimes some cases go well only with B12 supplementation and not the antibiotic responsive ones, but some cases with chronic enteropathies go very well with dietary modification, cobalamin supplementation if needed, and prebiotics, not probiotics. Okay. And I'm so sorry to show you the feces. Actually, this was sent yesterday. These are yesterday's feces, not 1 week after the treatment. As I told you, I called the owner yesterday and he sent me this. And, this is what I have in my phone. Most of my photographs, if I lose my phone, I don't know what people will think of me. Most of the photographs are feces of dogs and diarrheas. Anyway, so 1 week after treatment, we had complete resolution of symptoms. The fecal score, was ideal too. We stopped the antibiotics to banana after 6 weeks. And we had a delayed relapse. We didn't have an immediate relapse after 3 months after we have ceased the tilazine. So we re-administered tilazine 3 months after the initial presentation at a lower dose at 8 milligrams per kilo just once per day for 2 to 3 weeks with a resolution of symptoms again. Do these dogs go out of antibiotics ever? As we said, some dogs know they could be on antibiotics 6 months per year. Other dogs, as they mature, yes, they do have less often relapses, okay? And Banana gained the ideal body condition score 4 months after treatment. Unfortunately, Banana was with the husband in vacation, and they didn't send me on time a photograph, but I hope that I have a photograph. Okay, and this is the last case. This is not the idiopathic antibiotic and ARD, antibiotic responsive diarrhea, but some people categorize these cases in the antibiotic responsive diarrheas, even though it's not small intestinal disease, it's large intestinal disease. And we're going to talk about that very thoroughly when we talk about large intestine in next webinars. But this is a very, very interesting case. So this is raki. Do you know what raki is? For the Greeks or the people from Cyprus that are here, they probably know what raki is. So raki is a very, very strong drink, alcoholic drink in Crete, in the island of Crete. And I've put it together with souvlaki and ouzo. These are the most famous, Greek foods and drinks. So this was the name of the dog because it had an owner that was originally from the island of Crete, as you can imagine. No one else would ever name the dog Raki. Anyway, so it was a boxer, female intact, 1 year of age. 1 year of age. Please do not give boxers that are admitted to your clinic, the young boxers that are admitted to your clinic, steroids, because they could die. These boxers actually with this disease that I'm going to tell you were dying out of immunosuppression. So 1 year old, so we're certain that at least for the beginners, as a beginner, we're not going to give any steroids, okay? Long history of chronic large bowel diarrhea, unresponsive to bendazole, to dietary trials, and to metronidazole for 4 months. This dog was on metronidazole for 4 months without any improvement of clinical signs. And I will show you how emaciated it was admitted to the clinic. So it had all the classic symptoms of large bowel disease, hematochezia, tenesmus, mucus, and blood in the feces, increased frequency of defecation, plus regurgitation and vomiting. Okay. The physical examination findings, bright and alert, lip licking and hypersalivation, because this dog really had nausea. Okay. The temperature normal, the heart rate normal. The CRT was a bit prolonged due to dehydration. And of course, the body condition score was very, very low. The respiratory rate normal, okay? And the rectal palpation, always do in diarrheas, always do a rectal palpation, painful, irregular and firm, a raised rectal mucosa. So the rectal mucosa was very irregular. Always do a rectal palpation in the physical examination of a gastrointestinal patient. You have to do a very thorough oral examination, an abdominal palpation, and a digital rectal exam. The last one will give you so many information, believe me, it's a savior sometimes. You can, in the oral examination, you can detect a lot of things about the general health of the animal, like the hydration, the cardiovascular ictures, the color of the mucosa, uremic ulcers in the tongue, and also for specific GI diseases like primary oral disease or linear foreign bodies under the tongue, especially in cats, okay? And the digital rectal examination can give you a lot of information about identifying the diarrhea. If you don't see the diarrhea, or if you don't have photographs, if there's melena or not, collect a sample of stools right from the colon, okay, and the anus. Are there stools or not? Are there feces, fecal material or not? So this could, give you a hint about a potential obstruction, prolapse or intussusception. Anal disease, you can have, perianal hernia, do a very good digital palpation for beginning perianal hernias and anal furunculosis. Okay, a lot of information. Do the digital palpation. We will talk about these cases more thoroughly, as I told you, when we are commenting the large intestinal diseases, but just because this is an antibiotic responsive case, I wanted to put it here so that you have in mind structured all the antibiotic responsive diseases, chronic enteropathies in gastroenterology, okay? So the CBC is pretty much normal. The biochemical profile normal, except the total proteins, which are a bit lower, but it's the globulins, it's not the albumins. The albumins, though, you see that they are on the lowest end of the reference range, okay? But we still do not have hypoglycemia. And also we have a low cholesterol level. Low cholesterol suggests a lot of times, small intestinal involvement as well. So 10 days later, we did a very thorough investigation of her large bowel diarrhea. And because of the regurgitation and the vomitings, we decided also to do a barium test, which actually revealed that we had delayed gastric emptying and esophageal dysmotility in this dog. And you see how much emaciated she was, okay? And let's see her large, this is colonoscopy now. This is not small intestinal upper GI endoscopy. You see all these ulcerated regions in the large intestine. Very, very indicative of the disease that she has. At 1 year of age, you see that the ulcers go up to the ileocolic valve. This is a very, very severe case. And of course, we biopsy everything. Very diffuse ulcerations, circumferentially. We take the biopsies, and the technique of the biopsy is that I take out my forceps, okay? And then I pull it back and I go 90 degrees on the mucosa. This way I have very, very good biopsy chunks, okay? And the histopathology came out with past positive macrophages, okay, neutrophilic inflammation, 1 year of age, young adult dogs, okay, epithelial necrosis and ulceration, and in the fish examination, presence of attaching and invading E. coli, okay? And this is the treatment for the ulcerative, this is the diagnosis, histiocytic ulcerative colitis. This is one of the only diseases, one of the very, very few intestinal diseases that are actually cured. It's not like the antibiotic, the idiopathic antibiotic responsive cases that we have a lot of relapses. These cases are cured, actually. So in these cases, okay, I'm going to answer to that later because we had a question. So in these cases, we give antibiotics and we cure the disease, as I told you. Okay, the treatment is, let's go back a bit. And rofloxacin, 10 milligrams per kilo every 24 hours for 8 weeks. It's better, of course, I always take biopsies for culture. So I submit my tissue for histopathological examination and also for culture, because now we're seeing a lot of cases that are resistant to enrofloxacin, that are resistant to metronidazole. This is why this case was not this is not a common case of antibiotic responsive diarrhea. This is a ulcerative colitis of ichthyositic ulcerative colitis of boxers, which respond only to enrofloxacin. This strain of attaching and invading E. coli, okay, or to amoxicillin and clavulanic acid, or to anything that our culture gives us, okay? Antibiotic treatment directed by culture and sensitivity results. And of course, severely affected patients may exhibit rectal stricture formation. Okay, the test of choice is fish and colonic mucosal culture. Some cases go very well with amoxicillin and clavulanate, as I told you, for 3 months. And genetic risk factors there. Why is this disease? What is the pathogenetic mechanism of this disease? Genetic risk factors that render macrophages unable to phagocytize bacteria. Okay, so this is a second, the idiopathic antibiotic responsive diarrhea in German Shepherd dogs and in large breed and giant breed young adult dogs. The ichthyositic ulcerative colitis in boxers, in French bulldogs, in huskies. These are the breeds here that you can see them, but you can see them in mixed breed dogs as well. Young dogs as well, of 1 year of age, 2 years of age, okay, that do not respond to previous treatments and that you have excluded everything else. And let's see now, where are the antibiotics in GI diseases used? Are they used properly? First of all, I know that most of us overuse the antibiotics, even in cases that do not, that is not necessary. So in parvovirus infection, only if we have neutropenic patients and septic patients, okay. In antibiotic responsive diarrhea, after exclusion, of course, of all the other causes. In E. coli associated granulomatous colitis, as I've shown you to Raki, and in Clostridium in the acute hemorrhagic diarrhea cases that are attributed to Clostridiums, this is, controversial. Only if we have systemic illness, we treat the animals with antibiotics. If they're neutropenic, if they have high fever. Otherwise, we do not use, even in Clostridium cases, the antibiotics. Salmonella and Campylobacter, only we treat if the animals have systemic signs, if they have systemic illness, because we have a lot of cases that we can isolate Salmonella or Campi from the feces, from the fecal material of of healthy animals without diarrheas. Okay, so we only treat the signs in case of signs of systemic illness. Okay. Please do not overuse antibiotics. First, do not overuse corticosteroids, and secondly, do not overuse antibiotics. Okay, and let's go to, I'm on time, and let's go to the 5 pitfalls that we should never, ever, that we should pay very much attention to. Okay, the take-home messages. Chronic intestinal disease may not always be exhibited with vomiting and diarrhea. So we have to keep in mind that it's different to have small bowel disease versus small bowel diarrhea. We can have malabsorption, we can have small bowel disease without diarrhea. We can have a cachectic animal, for example, severe weight loss. And this is intestinal, this could be intestinal disease, but not small bowel diarrhea. When a dog is admitted with diarrheas, we do not do symptomatic treatment. Do not give, loperamide, do not give, just have a diagnosis, because it's very dangerous to prolong it and to have chronic, and I mean with chronic diarrhea cases, okay, not with acute diarrheas. And even in acute diarrhea cases, we have to have a diagnosis, a definite diagnosis. Even before hematology and biochemistry, please perform your fecal analysis for parasites, okay? Fecal cultures, as I told you, do not have any clinical relevance for canine and feline patients. Not all cases of diarrhea are malabsorption, and not all cases of malabsorption are diarrhea. And beware of young dogs with diarrhea. It is less likely to be steroid responsive enteropathy. This was a very, very nice webinar today, because this was something that I always wanted to, to give you hints and clarify these terms like SIBO, like intestinal dysbiosis, like what is the antibiotic, the idiopathic antibiotic responsive diarrheas. Where do we use antibiotics in gastroenterology? Okay, and I'll be happy to answer any of your questions. Put them in the chat, or you can also send me an email.
Okay, if you have some other questions, you can contact us or send email to Dr. Vasilicki. Okay, it's a very brilliant speech. Thank you, Dr. Vasilicki.
Thank you everyone for attending. I know it's a summer, it's summertime, everyone is out on vacation, but whoever did not have the chance to attend it live, you will see it recorded, and you will watch it recorded, and I will be very happy to answer any questions. Okay, let's see if we have a question. Thank you. Thank you too. Thank you. Thank you.
Yeah,
thank you, everyone.
Okay, I want to mention that each attendee will receive our record when it is finished, and it will send it by our partners in your area. So keep in touch.
And I will see you next time. And next time we will probably do the steroid responsive diarrheas along with the protein losing enteropathy cases, which are very, very interesting and important on how to handle that and how to manage them.
Yeah, looking forward to next webinar.
Looking forward to seeing you as well.
Yeah.
Goodbye, everyone.
Thank you, everyone. Goodbye.